Okay, hi guys. Hope you're doing great. We meet for another session today. That would be LRR General Medicine. So welcome to the session. And the objective of this is to, in the last few days, because just reading the notes may actually result in not too much of data going in the brain. So what we thought was that towards the end, as a support system, what we can do is discuss some MCQs. Which would help you, rewire your neurons and recharge your neurons. Meanwhile, so that you can sit back, relax, and I do the heavy lifting. Normally, like it's you guys who are doing the heavy lifting when it comes to solving the MCQs in the app. But then you tend to tire out a bit. So this time I'm gonna be doing like or assisting you in fact in the heavy lifting part. So let's get started. Obviously, I know the time is or the clock is ticking and it's very close to the exam. But then yeah, I mean this is a critically important subject and then has a good weightage as well. So all subjects are equally important. I can say that let's give every subject the due importance that it actually needs, and we can get started. So give thumbs up, quick thumbs up with respect to the audio and the visual part, and then we can proceed with the very first question for today. Here it is, the question, and you need to do a quick voting for this. Try to keep your reflexes sharp and try to answer it in the shortest possible time frame. That would help you, get to the actual exam status as well, or the actual exam scenario as well. So, okay, guys, we start with this patient who underwent a kidney transplantation in 2024, and then there's a decline in the kidney function. And the patient is on anti-rejection medicine. So, like, initially I'm thinking that this could be an opportunistic infection that could be developing. And considering that there's an opportunistic infection in fact present because the urine cytology is given here, so you guys can do the commenting for like what would be the most appropriate step for management of this patient. The most important thing is INI-CET has like multiple correct options present. So it's more of like scuba diving where you have to, do a much more effort as compared to simply swimming in a swimming pool, as I say always. So the bottom line is that in this particular case, I got 2 as an answer. That is option number A and C. Well, this is not cytomegalovirus now. First and foremost, like this is not cytomegalovirus, because if I was saying cytomegalovirus, I would have talked about those classical owl eye appearance present. Guys, this is a basophilic ring. If you check it out, no, it's a blue color ring which is present inside. So first and the foremost thing that you need to pick up is that what is the opportunistic infection that is coming up, and like time frame, I can say like, within this much time, this infection is present. But then overall, we need to keep our mind open to all. So I can say that this is not a basophilic inclusion body, but it's a basophilic ring which is seen in the renal tubular cells. These are the shed renal tubular cells. They've been infected by the BK virus. They've been infected with the polyoma virus. So the first foremost thing that you need to pick up in this question is that not every question related to kidney transplantation is going to be cytomegalovirus. That's a traditional thing that has been asked in INICET exam, that he'll make it sound like CMV, but then it is decoy cells, and that immediately removes ganciclovir from the picture. And if I increase the immunosuppression, I mean, that is because this is not a kidney rejection, it's an opportunistic infection. So if I increase the dose of immunosuppression in a patient, then the immunity levels would decrease even further. So it doesn't make sense, and there is no rule of Foscarnet as well. So the correct answer for this is option number 1 only. So for this question, you need to answer like as 1, 2, 3, 4. The answer is A, that is reduce the dose of immunosuppression. As I said, like this guy, there could be 2 reasons why the transplant is not working. The grafted organ is not working. One reason is that the chap had rejection. The second possibility is an opportunistic infection. The guy is compliant with medication. So in those circumstances, we have to go and reduce the dose of immunosuppression, and there is no drug of choice per se for management of BK virus, also called as polyoma virus. The main concept behind this question was the presence of decoy cells. So I think we sorted for this one. Good answers for the first answer, like the first one, though there were certain errors initially, but then you guys went back into introspection and were able to get to the final answer. Moving to the correct question, we have this chap. He has a triple vessel disease, very so common in India, and is brought to the emergency room in an unconscious state. traditional case of a crashing patient, unrecordable BP, pulse is not palpable. And if I say start talking more, then the answers will become obvious. So you guys need to do the talking at the moment. Like you called the patient out by his name as well. And because maybe the person accompanying the person had told you that this is the name, and in the file also, in the admission slip also, you can check out the name. So you called the name, there was no responses that was coming up, so I can pick up like two answers there, B versus D. So one is obviously we have to give chest compressions, they're present in all of the four options. I'll have to attach defibrillator leads and give adrenaline. Well guys, in this question there is no mention of any ECG finding. No, there is no ECG finding given in the question. Like suppose the question said that the person is having asystole, then it makes sense. No, like then it makes sense that I am able to pick up asystole, I need to give adrenaline. But at the moment, like there is no asystole given in the question. Read the question, guys. This is a standard advanced cardiac life support scenario. What you need to pick up in a question is that what is the rhythm given? Is it shockable? Is it non-shockable rhythm? So in this particular chap, there is no ECG that is given in a question. So I will not answer as adrenaline. There's no mention of any ventricular tachycardia. So I will not be answering it as amiodarone. So that gives me a pretty good idea to arrive at the correct answer. Yeah, keep it simple, man. If a patient comes in the hospital, in fact, the American Heart Association guidelines, the October version of 2025 has come recently, and they've just said simple things only, which you already know. There's nothing new, like, you know, that you are not aware of. The standard thing is that you have to start CPR in a patient. After that, bag and mask ventilation and give oxygen to a patient. The only thing that they've added is the word bag and mask ventilation. Here earlier it was just give oxygen, but it was a very non-descriptive way. Now he says bag and mask ventilation. So that's what we do in the hospital also. No, any patient who's coming, we go in for a CAB. So circulation, airway, breathing is what we are trying to do in this case. So the point is you go for circulation, that is CPR. At the same time, you give bag and mask ventilation, give oxygen to the patient, and attach him to a defibrillator. So the correct answer for this particular question is option number D. Guys, I'm still getting C in the feed. Please appreciate there is no mention of any ventricular fibrillation. You first have to attach the defibrillator and analyze the rhythm. That's what you do now, that you attach the defibrillator leads and then you have to check out the rhythm. If it is a shockable rhythm, then you give RTC shock either for a PVT or for a ventricular fibrillation. So at the moment in the question, he's just asking basic thing that even before what are you gonna do? Simple thing is circulation, airway part, that is, and attach the defibrillator lead. So the correct answer for this one is option number D. All you need to do is keep it cool, right? We tend to get into pressure whenever we are reading a patient of a crashing blood pressure and we start analyzing things from the perspective of either a shockable or a non-shockable rhythm. Step one would be to know whether the guy is in a shockable or non-shockable rhythm. First attach the defibrillator leads. So it is a straightforward answer. Overthinking is the reason why this kind of a question can go wrong. And we move on to the next one for today, where we have this woman. She's undergone a hysterectomy with a bilateral salpingo-oophorectomy. Then is not specified the reason for this, but it could be possibly maybe old lady. So I'm suspecting probably some kind of a malignancy as well. And then you can notice that there is that big clot bang in the middle of the pulmonary, artery. So the diagnosis of this patient is very clear that we're dealing with a pulmonary thromboembolism. And the moment I'm writing this, you can also see that because it's a big clot, the lung circulation will be very severely affected. The perfusion part would be affected. So he says like, what is gonna be, and don't worry, like I will be भूत जैसे लग रहा हूँ अभी मैं आपको. So there's a transient glitch and you would be you'll be getting a FMG live session as well. So I'll be looking like a bhoot to you at the moment, but I'll come back, right? So don't worry. And meanwhile, you can keep on attempting the question. So we're dealing with a case of pulmonary thromboembolism. And he says that which of the following is the correct pathophysiological finding for this particular case. So it happens, no, in India also, like you are in a labor room, you're taking a delivery and the electricity would go off. And then if you are putting a center line and the electricity would go off you. So this is very natural. So for pulmonary thromboembolism, guys, the basic point is that there is no perfusion in the lung. So first and foremost is this gradient, no, alveolar arterial gradient, that is 5 to 15 millimeters of mercury. And what will happen in this particular case is that this chota wala A will tend to decrease, because ultimately a gas is going in the alveoli, but it is not reaching up to the levels of the alveoli because blood supply is not there, no? So small wala A is less. So one, in this particular condition, the gradient would be more. And second problem in this patient is increased physiological dead space as well. I'm saying the physiological dead space is more because ultimately there is no perfusion of the lung in this case. So B and the C are the components which are correct in this case. So I was getting a C and a D also correct. That is DLCO, no, diffusion capacity of the lung for carbon monoxide. DLCO is a parameter that is mainly evaluated for those cases where there would be like a pulmonary fibrosis happening or like asthma. But in this case, like the more logical statement would be one, that this gradient is mathematically increased. Normal is 5 to 15, छोटे वाला ये कम हो गया क्योंकि ब्लड जा ही नहीं रहा ना एल्वोलाई के अंदर, तो इस वजह से मैथमेटिकल ग्रेडियंट इंक्रीज होता है. सेकंड, डेड स्पेस, नो, यू नो दैट डेड स्पेस बेसिकली मीन्स दैट इज द अमाउंट ऑफ गैस दैट वुड नॉट बी वेंटिलेटेड every time we breathe in. So in this case, that dead space is increased because there's no perfusion of the lung. So pure, I would say, physiology slash medicine kind of a question, that is pulmonary thromboembolism, and we just had to pick up two correct statements there. Moving to the next one, we have this smoker. He came in an unconscious state after multiple episodes of seizures. So this guy is a smoker, and he has had multiple episodes of seizures. Okay, so I thought that maybe the cancer, maybe he's having some cancer which could have gone into the brain. Since he's saying a cigarette smoker, old man, I was thinking some kind of a malignancy. Then he had the first marathon of his life, and the workup shows blood urine nitrogen is elevated, so he could be dehydrated because of the marathon race. And then the urine output is like 720 ml in 12 hours. So that makes it like, I can say no, not reduced. I'll put it like this. Normal urine output is like 1 ml per kg per hour. Normal person would be 60 ml per hour. No, normal person would be like 60 ml per hour. So multiplied by 12, 720 makes pretty decent sense. Then you are noticing the sodium value in the patient is very less. So it's a typical case of hypovolemic hyponatremia. And considering that the guy has run his half marathon first time, especially if the person has not hydrated himself very well, there is a very high chance that the patient will end up with hyponatremia, which can be dangerous enough to contribute to development of seizures in this patient. So the first and the foremost thing for this particular patient is that I need to give a bolus, because initially when you are having an acute onset hyponatremia, we will have to give a bolus of hypertonic saline for management of this patient. That is the initial management that we'll be doing. So we will increase the value of sodium from 120 to, let me say, 125. But then from 125 to 135 will be a slow process. This would be done over the next 48 hours. So what I need to do in this patient is, since I'm dealing with a case of hyponatremia, initially I will be doing a fast correction. That would be to control the seizures. And after that, subsequently, what we'll do is we are gonna give a slow correction in this patient. So two things need to be done for this particular chap. That is, first a bolus, so that sodium can come to the range of 125 or a little higher. That's an increment of only 3 points only. But that 3-point increment will stop the seizures of this patient. That is the point. Is it an acute or a chronic one? That is what I wanted you to understand, that this guy had run the first marathon of his life. He's a smoker, but there is no mention of any malignancy or any cancer in a patient. So it's an acute onset hyponatremia. In any patient of acute onset hyponatremia, the first thing that we do is control the seizures. In any patient of, this is a case of acute onset hyponatremia. Now the point is, first what do? You control the seizures, so hike to 125. But then subsequently, that hike from 125 to 135 would not be good idea in a short duration. I don't want to, I agree to the fact that in chronic onset hyponatremia, we should be doing is a slow correction. But even in this patient, there is no rush now. So there's no specified duration that is given in this question, that only in this much time you need to do it. But the point is, we first need to control the seizures, and after that, then cause a gradual rise in a patient. If the seizures will stop, then it's okay. Like if he's in a position to take orally, I can be even giving salt capsules to this patient. But then most of the time, the sensorium will not come back to normal immediately. So we can continue with our saline infusion subsequently. That's a gradual infusion. The logic is stop the seizures and then do a gradual infusion of hypertonic saline. So in this particular case, the correct answer is A and D, that is the first one. And I had a query for ECG. We did ECGs, I think yesterday, day before. We did 20 ECGs in 30 minutes. Even in this session, those ECGs are present. But in case you are interested, we deliberately segregated them so that you could focus on the ECG component separately. Okay, so we are moving to the next one. Yeah, there is a risk of central pontine melanosis. We want to avoid that. That's definitely on. But here the concept was, what would you do? That is, control the seizures and then do a gradual rise till the patient's sensorium becomes okay. Okay, we have this lady admitted with sepsis. You put in a central line because any patient would need a good vascular access. You can monitor the hemodynamics relatively better. And after putting a central line, you are noticing that the blood pressure of the patient is falling. There's a sudden onset distress in a patient. Plus, he's also mentioned regarding like this murmur as well. So he says like, what is the next step in management of this patient? So you guys can quickly comment in here. The chap is okay. I had one B and D coming up, that is perform chest x-ray and put a wide bore needle in a patient. Good, that is a good attempt. Waiting for more people to comment for this one. Very, I think, a logical scenario. Every time you put a central line in a patient, then there can be two possibilities. Either the chap can have is a pneumothorax, and if it is not going to be a pneumothorax, then central line can contribute to air embolism as well. The key thing in this question is mentioned like a machinery like sound of the murmur. So that is the characteristic thing that is telling you that this guy is having is a venous air embolism. Unfortunately, after putting a central line, there is rush of air bubbles into the right side of the heart, which is causing air embolism in this case. Whenever there is a air embolism happening, the key word in this question which you had to pick up was this word machinery like sound murmur present. And the moment you pick this up, this is also called as a mill wheel murmur ना, जो एयर एम्बोलिज्म का मर्मर होता है उसको मिल व्हील मर्मर बोलते हैं. And then what you need to do is first keep the patient in durant position. Durant position would mean turn the patient immediately to the left side. That makes sense. And clamping the line also makes sense. So it is A and C which are correct in this case. So therefore the correct answer for this would be option number 2. In case it was a pneumothorax, suppose this question mentioned absent breath sounds, absent air entry, some kind of a tracheal shift, mediastal shift. If that kind of information was given, then yeah, I need to think in terms of a chest x-ray, and if it's a tension pneumothorax, I might even have to decompress. But given so far so good, we are having that classical mill wheel murmur, as you can see here, on auscultation, machinery like sound murmur is heard. That's actually the thrashing or the mixing of blood and air in the right side of the heart. I mean, air has no business to be in the heart. If you are mixing a blood in the air in the heart, it's always going to contribute to obstructive shock. The type of embolism which is present in this case, why the BP was crashing, was that the output from the right ventricle into the pulmonary artery is getting compromised. So what we are getting is the obstructive shock developing, and that's why we need to clamp the line and we need to turn the patient immediately to the left side. So I think we are sorted for this question's approach. I think every time you read a question on center line, don't assume it's always going to be related to pneumothorax only. So relax, guys. I mean, you guys are rushing into answers and you need to take your time. I mean, give 30 seconds to 45 seconds while reading a question with me. And like, I'm doing the heavy lifting for you because I am talking and I'm simultaneously giving you verbal cues as well. But then what happens a lot of time is we tend to assume that this is going to be a complication related, which can result in air is going in, no? Air is going in, so I need to clamp the line now, right? Clamp the line or like secure the airlock properly. That would be what is gonna be doing. Yes, guys. Yeah, I'm getting your answers, guys. I'm getting your answers. That's why I'm saying no, that a lot of people are rushing into the commenting part there. Okay, if we move to an alcoholic, he's an unconscious patient, he's passing black colored stools for the past 2 days. Random blood sugar is like 65, INR is 10. That's a cause of concern. And he says like, what are you gonna do for management of this patient? Guys, this is not a question of Wernicke's encephalopathy. ये कोई Wernicke's encephalopathy थोड़ी ना, इसमें कोई गोवा वाला फीचर दे रखा है क्या? There is no global confusion, there is no ophthalmoplegia, there is no ataxia happening in this case. This is not a question of Wernicke's encephalopathy. A और B तो बाहर हो जाता है भाई. Alcoholic को black colored stool pass हो रहा है, INR is 10. That means the chap is having coagulopathy. and at the same time the guy is like, he is having a liver failure, and because of this liver failure he can actually bleed internally, and that could be lethal as well. So what I need to do for this patient is, one, I need to give fresh frozen plasma. I'm getting D as a vocal answer towards the end. तो विटामिन के अगर मैं दूंगा भी तो लिवर तो खराब हो गया ना यार, तो क्या वो विटामिन के असर करेगा? नहीं करेगा ना। दिस गाय इज अनकॉन्शियस, मतलब उसको एंसेफेलोपैथी भी हो रही है। और हेपाटिक एंसेफेलोपैथी के लिए क्या देते हैं? लैक्टोलोज देते हैं ना। फॉर हेपाटिक एंसेफेलोपैथी यू नीड टू गिव लैक्टोलोज बिकॉज दैट विल reduce the bacterial load in the GI tract, because bacteria is the main source of ammonia production in the body. So there are two problems in this guy: coagulopathy, how do you know that? Bleeding, and melena. And at the same time there is mention of unconscious status, that is gonna be encephalopathy. Considering the two, his liver is failing, so I need to do two things in a patient, that is fresh frozen plasma, and then yeah, ऐसे ही होता है यार। इनिसेट में भी the same thing is what we're trying to replicate. That is why this is a match practice for you couple of days before the exam ना। The answer to this question is not D guys. Why? Because vitamin K अगर दोगे भी तो the hepatocytes are already severely compromised, no? The critical mass of hepatocytes is not there, so vitamin K causes there's gamma carboxylation of clotting factors, and then you have is like the clotting process initiated, but यहाँ liver mass ही नहीं है ना, तो I need to give treatment for hepatic encephalopathy and treatment for the coagulopathy component in this patient. Random blood sugar 65 तो critically low नहीं है ना। 65 में तो आपकी मेरी भी अगर खाना नहीं खाएंगे तो 65 चली जाएगी ना। 70 से anything less than 75 is hypoglycemia, तो it's not a neuroglycopenia ना, इट इज़ नॉट अ न्यूरोग्लूकोपीनिया। यही ब्लड शुगर 25 होती तो मैं मान लेता आपकी बात की भी पेशेंट अनकॉन्शियस हो गया। 65 तो नहीं हो जाएगा ना, 65 पे तो अनकॉन्शियस नहीं होती है, रेदर इट इज़ अल्कोहलिक एंड अनकॉन्शियस। देन कॉमन चीज़ें पहले सोचो ना, अल्कोहलिक है, अनकॉन्शियस है, ब्लीड भी हो रहा है, तो ही इज़ गॉन इन टू fulminant hepatic failure, possibly acute on he had a chronic liver disease and now the liver is decompensated, so we need to give lactulose to reduce the ammonia concentration in a patient. The correct answer for this one is option number C. So we move on to the next one, where we have this 25-year-old female, and she's come with these recurrent episodes of thick viscid sputum. Okay, so the age group is 25. There's a lot of viscid sputum in this patient, sticky sputum. The patient is also an asthmatic. Okay, so he's given me a hint also that is an asthmatic patient, lot of sticky sputum. Then is given imaging findings, immunoglobulin E levels and absolute eosinophil count. That's anyway increased in asthmatic patients considering the allergic perspective. And he says like, what are we gonna do for management of this patient? So yes guys, yeah, that's why, no? Okay. So for this particular case guys, I think it's a pretty straightforward one, that because the word central bronchiectasis is given in a question, we'll say that the chap is having an allergic bronchopulmonary aspergilloma. And for allergic bronchopulmonary aspergilloma, we would not be giving voriconazole, no, because it is not a case of invasive aspergilloma. If it was an invasive aspergilloma, then voriconazole, postconazole and things like that do make sense. But for allergic bronchopulmonary aspergilloma, first word is allergy, right? And is an asthmatic, so we need to give steroids. And second, we need to decrease the colonization of the airways, because this condition is actually a hypersensitivity reaction to the aspergillus fumigatus. It's like a colonization of the airways and a hypersensitivity reaction to the same. So I need to give steroids and I need to give itraconazole for this patient as well. So therefore, like, you can arrive at the correct one for this case. That would be option number 4 would be the most appropriate treatment for this patient. I've highlighted this multiple times, asthmatic, and then there's a viscid sputum, tenacious sputum, black sputum, brownish plugs, those the kind of vocabulary given in a question. Then yeah, that's a good point कि steroid से तो infection हो जाएगा, यही तो बता रहा हूँ बच्चे. This is not an infection, it's a hypersensitivity reaction to the fungus which is colonizing the airways of the patient, and this fungus could be colonizing the airways of you and me as well. So yes, तभी तो ये, this is like we want to decrease the load of the fungus and we need to control the asthma inflammation and at the same time decrease the hypersensitivity. So yeah, good point. Steroid नहीं देते acute infection में, पर ये infection है ही नहीं ना, तो इसको सुनना दोबारा से, राइट? बिकॉज एस्परजिलस पे जब भी सवाल आता है तो हमें क्या लगता है कि ये क्वेश्चन तो ना इन्वेजिव एस्परजिलोमा का होगा. एंड ओके, बॉस, आपने बॉस पढ़ लिया, ओके। सो इन्वेजिव एस्परजिलोमा, अगर ये सवाल होता है इन्वेजिव एस्परजिलोमा का क्वेश्चन कैसे होगा उसको देख लो, बिकॉज आई एम हैविंग लॉट ऑफ क्वेरीज की सर ये तो वोरिकोनाजोल वाला क्वेश्चन बनता है। इफ इट इज इन्वेजिव एस्परजिलोसिस द क्वेश्चन वुड बी लाइक ही विल मेंशन अ फंगल बॉल इन अ cavity, like this guy had TB, maybe he took treatment for TB, but ultimately there is a cavity in the lung. So if you read a question in which there is a fungal ball which is developing in the cavity, and then the chap ends up with hemoptysis because aspergillus is a angio-invasive organism. So if a question was mentioning like a pre-existing cavity in the lung due to TB treatment has been taken, and he mentions that the CT chest shows a fungal ball in the lung cavity, and at the same time mentions hemoptysis, that is when you would think in terms of invasive aspergilloma. And yeah, then you'll have those hints, no, that crescent sign described in a question and then halo sign described in a question. It's like a halo sign, which will be a more appropriate terminology. So I mean, if that imaging was given, yeah, I would have thought in terms of invasive aspergilloma, but here the examiner himself has given me that very good hint, no, that the finding present in this case is that of a central bronchiectasis, which totally changes the entire game in this person. So the correct answer for this one is 4, and we can move on to the next one, because pneumonia is anyway the incidence of this would be increased. We are having a big patch that is not affecting the I mean, we are not getting the cell out sign in this case. Now the right heart border can still be made out. So this looks to be a right lower zone pneumonia. I mean, though I need a lateral view, but I'm saying that the way it is, the right heart border is very well visualized. So this is unlikely to be right middle zone pneumonia. Looks like a right lower zone pneumonia. AEC होता है एब्सोल्यूट इस्नोफिल काउंट ना, भाई अस्पताल में काम करे हो तो आधा टाइम तो शॉर्ट फॉर्म पे ही चल रहा होता ना सब कुछ. This guys is a right lower zone pneumonia. It can involve some part of the middle lobe sometimes depending on the organism, but then because cell out sign is not present, so itraconazole ताकि हम फंगल कॉलोनाइजेशन को रिड्यूस कर पाएंगे ना. देखो आप सबने ना एस्परजिलस को बहुत बारी पढ़ा है माइक्रो में और पैथो में, पर अब मेरा सजेशन है कि इन्फेक्शन अभी क्योंकि थोड़े से दिन बचे हैं एग्जाम में, तो इन्फेक्शंस वाला जो सेगमेंट है ना, मैंने जो मेडिसिन में बताया हुआ है उसको एक बारी 2.5 घंटे में प्रैक्टिकल वाले सारे बता रखे हैं, उसको एक बार फास्ट लूप में सुन लेना, तुम्हारे कंसेप्ट क्लियर हो जाएंगे इन्फेक्शन से रिलेटेड जो कॉमन वाले पूछता है. मैं यहाँ पे किसी ने कॉइंट पूछा इसलिए बोल रहा हूँ कि भाई ये एक हाइपर सेंसिटिविटी रिएक्शन टू द फंगस है, ये एक इन्फेक्शन नहीं है. तो हम एस्परजिलस नाइगर की बात नहीं कर रहे, फ्यूमिगेटस की बात कर रहे. ओके जी, तो यहाँ तो आई थिंक आई मेड माई सेल्फ वेरी क्लियर बिफोर यू कि 65-year-old पेशेंट है, उसको रस्टी स्पूटम है, देन देर इज लाइक रेस्पिरेटरी रेट इज 36 एंड देन द एज ऑफ द पेशेंट इज 65. तो वैसे ही लाइक स्कोर दो की तरफ तो जा ही रहा है. डिसओरिएंटेड भी हो गया, और डिसओरिएंटेड हो गया तो वो तो सीधा ही आईसीयू में लेके मुझे जाना है. ही इज़ लाइक उसके बाद तो ब्रोंकियल ब्रीदिंग वगैरह तो बाद की बात है कि भाई परकशन पे डल नोट है, देर इज़ लाइक bronchial breathing in this patient. So I know that I'm dealing with the case of lobar pneumonia. The score of the patient is going to be a score of 3. So I need to take this guy into intensive care unit, and I need to ensure that in this particular patient, ventilator facility should be available if God forbid he needs it. And in those circumstances, I need to give to this patient respiratory fluoroquinolones, which are not in the options. Like if it was saying ceftriaxone, azithromycin, I would have still considered it. But then ampicillin से तो काम नहीं चलेगा. I need to give ampicillin along with beta-lactamase inhibitors. That would be ampicillin, sulbactam and azithromycin for this patient. Ofloxacin आंसर आ रहा है बच्चे, मैंने बताया ना, ofloxacin is not a respiratory fluoroquinolone ना. रेस्पिरेटरी फ्लोरोक्विनोलोन्स में तो लेवोफ्लॉक्सासिन आता है, मॉक्सीफ्लॉक्सासिन आता है और जेमेफ्लॉक्सासिन आता है. द आंसर टू दिस क्वेश्चन इज नॉट ऑप्शन नंबर डी. आई जस्ट क्लैरिफाई वंस अगेन. Ofloxacin would be mainly working on gram-negative organisms. We are dealing with gram-positive and atypical organisms in this case. तो इसका आंसर डी नहीं है, because what are the antibiotics in respiratory fluoroquinolones? I'll just write the short form. Today LMG is not light machine gun. It is levofloxacin, moxifloxacin and gemafloxacin, and obviously like ofloxacin does not belong to the list. So yeah, it is geme, not gatifloxacin, it is geme, right? तो gatifloxacin again UTI में यूज करते हैं ग्राम नेगेटिव में. तो डी बाहर हो जाता है. सी ऑप्शन में सेफ्ट्रॉक्सिन विद वैंकोमाइसिन. सो वैंकोमाइसिन नहीं ना, बिकॉज ये तो ट्रीटमेंट मेनिंजाइटिस में देते हैं ना, Ceftriaxone with vancomycin is for empirical treatment of pyogenic meningitis, where only Streptococcus pneumoniae is the only organism. But then in patients who have come to us, they could be like a typical and atypical, both are present. So what I need to do for this particular individual is that I'll be using ampicillin sulbactam with azithromycin for management of this patient. So एक बारी जो treatment of आई मीन कर्ब स्कोर 2 और 3 के जो ड्रग्स हैं उनको मैं फिर से बोल देता हूँ. फर्स्ट आंसर इज ऑब्वियसली रेस्पिरेटरी फ्लोरोक्विनोलोन्स, बट लॉट्स ऑफ टाइम इट वुड बी लाइक बीटा लैक्टम. I mean, the basic issue is ampicillin alone will not be sufficient. So you need to add something, right? And that would be either amoxicillin clavulanic acid, or it can be ampicillin with sulbactam with azithromycin that would be used. And you guys can comment here which atypical organism can present as a typical organism also. Question for you guys is which atypical bacteria, which organism, which is an example of atypical bacteria, can appear or can cause radiological findings of typical pneumonia as well. यस, लीगेनेला, एब्सोल्युटली. लीगेनेला जो है वो लोबार निमोनिया कर सकता है, मल्टी लोबार निमोनिया भी कर सकता है. सो लीगेनेला इज वन थिंग जिसका मुझे कवरेज देना ना. व्हाट आई एम ट्राइंग टू गिव इज अ रैशनल कि क्यों एजिथ्रोमाइसिन यहाँ पे आंसर्ड है, बिकॉज द क्वेरी ऑफ मोस्ट पीपल इज कि बॉस अगर एक्सरे में लोबार कंसोलिडेशन दिखाई दे रहा है, लोबार निमोनिया का फीचर है, देन व्हाई आर यू वेस्टिंग योर टाइम गिविंग एजिथ्रोमाइसिन. तो द आंसर टू दैट इज दैट azithromycin is going to give coverage for especially Legionella pneumophila, which could be present in the case, and is one atypical organism which can present as a typical organism in the form of consolidation as well. So yeah, I had good answers for this one. Let's move on to the next one on the discussion. Okay, so I have this guy. He's brought in by the medics after a motor vehicle accident. The chap has had multiple fractures. He's hypotensive. He's tachycardic. Heart sounds are okay, but then the neck veins are distended. There's a decreased breath sounds on the left side with a tracheal shift also. So makes it relatively easier. One question on this always comes, and therefore like a trauma case with mediastinal shift has been described. He has himself mentioned why sulbactam, because ampicillin alone, beta lactamase inhibitor na. Otherwise the bacteria most of the time nowadays, if you're putting somebody in intensive care unit, right, if you're putting somebody in a ward also, that means he's critically sick. That must be meaning that the bacteria that is present is not going to be sensitive to routine penicillin group of drugs. I need to give a beta lactamase inhibitor to the patient, so that's why like sulbactam needs to be added. Do check out the treatment of, like in rapid revision, do check out the pneumonia treatment. Though I've said it verbally, I said that again, respiratory fluoroquinolones first. Otherwise it is like ceftriaxone with azithromycin, or it is ampicillin sulbactam with azithromycin. The rationale for azithromycin is what I've already given. ओके जी, तो यहाँ पे हार्ट साउंड्स तो नॉर्मल हैं, बट दिस लुक्स टू बी अ केस रिलेटेड टू न्यूमोथोरैक्स, सो दैट्स द कॉज ऑफ कंसर्न. एंड द नेक वेन्स ऑफ द चैप आर डिस्टेंडेड. दैट टेल्स मी दैट the superior vena cava is getting compressed. There is air at positive pressure, so looks to be a tension pneumothorax in a patient. And you guys can help me out with the answer for this question. See guys, why I included this question is because this question actually came in the last time July's FMG paper, and these were the exact options that were present. I'm saying the word tension pneumothorax. Why I'm saying tension pneumothorax is because there is a evidence of neck veins being distended in a patient. That tells me like he's not given the blood pressure value. But if the neck veins of the patient are distended, it means the SVC and the IVC are getting compressed. If the neck veins are distended, it means that there's an obstructive shock happening in the person, and therefore this is a case of tension pneumothorax. Now, considering decreased breath sounds with tracheal, yeah, I mean, considering the decreased breath sound, it can be hemopneumothorax as well. But then the point is, if it's a pneumo which is causing mediastinal shift so big that it can contribute to tension pneumothorax in a patient, what we need to do is we need to evacuate the air. सो वी विल पुट अ चेस्ट ट्यूब, बट यार चेस्ट ट्यूब डालने में तो टाइम लगेगा ना. अभी अगर केस आया तो आपको लगता है कि इमीडिएटली लिखा है क्वेश्चन में कि सबसे पहले क्या करोगे, तो मैंने चेस्ट ट्यूब डालूंगा. तो इतना भी कोई स्किल्ड होगा, 5 मिनट तो लगाएगा ना चेस्ट ट्यूब डालने में ना. यू नीड टू गेट द किट, यू नीड टू मेक अ इंसिशन, यू विल यूज दैट कैलीस forceps and insert the tube, and it takes a time in this particular case. So the point is I need to do something immediately, that is a needle thoracostomy in this patient. The only thing is, yeah, second intercostal space, Harrison 22nd edition में भी हैरिसन का जो लेटेस्ट एडिशन है उसमें भी 22nd एडिशन में मेंशन्ड है कि सेकंड में करते हैं। वो ठीक है कि ATLS के जो गाइडलाइंस है उसमें फिफ्थ इंटरकॉस्टल स्पेस है, बट ये मैं इसलिए बोल रहा हूँ कि जो इस बारी का FMG का पेपर था उसमें भी यही ऑप्शंस थे, उसमें फिफ्थ इंटरकॉस्टल स्पेस नहीं था, जिसकी वजह से स्टूडेंट्स गॉट कंफ्यूज्ड, बट द आंसर स्टिल रिमेन्स द फैक्ट। वो मैं मानता हूँ भाई कि बच्चे में है सेकंड, मुझे मैंने ही बताई है वो बात कि बच्चे में सेकंड यूज़ करना है, एडल्ट में फिफ्थ वाला यूज़ करना है, तो पॉइंट सही है। लेकिन हैरिसन का जो स्टेटमेंट है वो सेकंड इंटरकॉस्टल स्पेस बोल रहा है, वो सेकंड क्यों क्यों यूज़ नहीं करते हैं आजकल कि भाई किसी के मसल्स का साइज बिग है तो नीडल अंदर नहीं जाएगी ना। तो आई एग्री टू दैट, बट देन इन दिस केस द करेक्ट आंसर इज ऑप्शन नंबर सी। बिल्कुल मैं मानता हूँ अभिषेक शिवानी दैट आपने जो बोला कि बच्चे में सेकंड इंटरकॉस्टल स्पेस यूज़ करते हैं, अडल्ट में भी कर सकते हैं, हैरिसन यही बोलता है। पिछली बार जब ये क्वेश्चन आया था तो हर कोई जो था सारे प्लेटफॉर्म्स ने ना ऐसे ही बोला ये बड़ा ना बड़ा अजीब सा क्वेश्चन था तो विल स्किप दैट एंड एवरीबडी मूव्ड ऑन, किसी ने ना फाइनल आंसर नहीं दिया। बट आई सेड कि भाई आई विल ब्रिंग इट ऑन राइट एंड आई विल ब्रिंग दैट क्वेश्चन राइट हियर इन फ्रंट ऑफ यू। Yeah, it can be a question where there could be a hemothorax in a patient as well. So we can debate about that as well. I mean, there's a hemothorax component present in the person because there is no percussion note that is described. But even in a hemopneumothorax, blood will go down and air will go up ना. So at least immediately क्या करोगे? मान लो आपकी बात मैंने मान ली कि blood भी है और air भी है, इतना तो मानोगे। अगर मैंने आपका blood माना तो आप मेरी air तो मानो, है ना। दोनों चीज़ें हो सकती है ना ट्रामा में। तो अब कुछ तो निकालेंगे, ब्लड निकालने में टाइम लगेगा, तो मैंने कहा भाई पहले एयर निकाल लेते हैं। दैट इज़ वाई द आंसर टू दिस क्वेश्चन। सो आई होप इट इज़ नाउ क्लियर। इमरजेंसी थोरैकोटोमी में OT में कैसे लेके जाओगे? जो पेशेंट हाइपोटेंसिव है तो एनेस्थीसिया वाला केस लेगा ही नहीं ना। यू नीड टू एटलीस्ट स्टेबलाइज द पेशेंट इन द मैनेजमेंट पेशेंट। और हेमोथोरैक्स में भी ट्रेकियल शिफ्ट इतना ज़्यादा नहीं होता ना, न्यूमो में होता ना। हेमो विल बी कॉजिंग वेरी लार्ज अमाउंट ऑफ ब्लड accumulation to cause a tracheal shift in a patient. तो दिस केस इज हैविंग टेंशन न्यूमोथोरैक्स एंड एग्जैक्ट वर्बैटिम ये क्वेश्चन था, ऐसे ही था स्टूडेंट्स का रिस्पांस कि सर मुझे एग्जाम में वो हेमो भी लग रहा था, न्यूमो भी लग रहा था, हेमो न्यूमोथोरैक्स भी लग रहा था। फिर मैंने मार्क क्या कर दिया, मैंने चेस्ट ट्यूब डाल दी इमीजिएटली वाले में। तो इमीजिएटली वाले में तो चेस्ट ट्यूब अगर डालोगे भी तो टाइम लगेगा, विच इज़ वाई दिस इज मेंशन्ड। या इफ फिफ्थ इज देयर आई एग्री टू द फिफ्थ इंटरकॉस्टल स्पेस। दैट इज वाई सेड कि भाई किसी ने इस क्वेश्चन को एड्रेस ही नहीं किया। दैट इज़ वाई आई थॉट आई शुड कम आउट विद दिस टुडे एंड से कि करना क्या है। तो 22nd एडिशन ऑफ हैरिसन 21st अभी भी सेकंड ही बोलता है, ATLS फिफ्थ बोलता है। वो ठीक है भाई, उसका रीज़न है ना कि फिफ्थ डाल सकते हो तो सेकंड में तो डाल सकते हो। ओके जी, फाइन। आई थिंक वी सॉर्टेड फॉर दिस वन, वी कैन मूव ऑन टू द नेक्स्ट वन। We have this 58-year-old lady with shortness of breath and she's having a pleural effusion in a patient. Now we need to do a thoracocentesis and then he's mentioned a lot of parameters. So the question is simply on Light's criteria. And considering the Light's criteria component, we need to be working out the information with respect to the pleural fluid protein and the pleural fluid LDH. So let's do a bit of mathematics here. My maths is bad, so I'm gonna do it the primitive way. The protein is gonna be like 2 grams. Okay, total protein effusion is 2 grams, and present here this would be 6.8. So 1 by 3, something like 0.3 present in this case. And then we're gonna do a pleural fluid LDH in the patient also. The LDH given in the effusion is 25. The guy is 75 in the blood, so that makes it again 0.3. So that's a transudate, right? So all you need to do in the question is, even if you don't get into mathematics, everything else that is present here is going to be an exudate. The only one transudate in this case is nephrotic syndrome. So the correct answer to this one is option number A. So yeah, guys, I think this was a good pickup in the discussion. And for the previous question, if somebody had mentioned a remark, so I'll just address this once again. This can be a pneumo and a hemothorax both present. But if I get an opportunity, I cannot treat immediately. I cannot like evacuate the blood immediately. It will take some time for me to put in a chest tube. So immediately what I can do is at least decompress the air part by at least, and that will give me some precious few minutes because the blood pressure is bound to pick up in this case. So yeah, even the other options, if you try to analyze, they would be all be exudative, but nephrotic is that transudative variety. So that's why the data can be filled up here, less than 0.5 and less than 0.6 respectively for protein and LDH. We sorted for the 10th one. Let's move to the next one here. We have this guy, he's having wheezing, shortness of breath for the previous few weeks. And now in this patient, like every time he's exposed to dust and exercise, the symptoms will worsen. Like after this crazy winter setting in with the smog, people who are asthmatics are bound to suffer. I mean, the FEV1 FAC ratio is given to be less than 0.7. So that makes it think in terms of either asthma or COPD. And then you are having a FEV1 increment of 20%. So that makes it like a diagnosis as asthma. Though initially I thought that he might be giving me a question on COPD as well. Now, once I know that there is like this particular value, he says what would be the most likely observed finding in this particular patient. I'm getting one answer as a forced vital capacity being increased. See guys, if an asthmatic is having an attack which is severe, then during an attack you having a forced vital capacity increase? No, it is a functional residual capacity. I think you guys are mixing with FRC. It is FRC that is increased. It is not a forced vital capacity in a person. So in an asthmatic patient, we have air trapping. The air trapping can explain the FRC in the patient to increase, but not a forced vital capacity. Guys, this is asthma. Simple thing is that in asthma, the number of blood vessels around the alveoli are relatively more. People with asthma tend to have a high. Bache, answer is not A. Answer is not A. It's not a decreased total lung capacity because air trapping hota na. On all asthmatic patients there is a air trapping that is happening, so total lung capacity कम कैसे हो जाएगा? Total lung capacity तो normal या increase होगा. The point is hypervascularization of the airways is what is asking here. I mean that's a standard question. जब भी asthma पे question आता है तो he would always be asking you regarding the DLCO value. In patients who are having asthma, DLCO is more. Though it is an obstructive airway disorder, the query that I get from those who have not read the topic is how is it possible to have an increased DLCO? The logic is there are more blood vessels. If you have more blood vessels around the airways, then better diffusion of gas will occur. Just remember my statement, hypervascularization of the airways. Hypervascularization of the airways is a feature that you always get in bronchial asthma, and this is the representation of the alveoli. So if I have more blood vessels, more gas can diffuse into all of these blood vessels, and if more gas can diffuse like this, it's gonna be beneficial for me. So it's gonna be like a increased DLCO for this patient. The correct answer is option number B. Yeah, after a lot of prompting, the answer came. So maybe the length of the question caused fatigue. So that's what I am trying to train you for. Okay. As far as management of asthma is concerned, do remember that in the treatment, according to the current GINA 2025 guidelines, patient is supposed to take a low dose inhaled corticosteroid or a SABA. SABA can be taken. Recommended would be a LABA with a rapid onset, as I have explained always. Because SABA, the problem is it will act for a short duration. Then again, the symptoms can come back. So we can give a low dose inhaled corticosteroid with a SABA or a LABA in a patient. Then subsequently, Dr. Morph, MP ortho obstructive with high DLCO is given. Then is low dose inhaled corticosteroids. Then it is like to be taken as and when they're required. Then they're to be taken daily. All I want to bring to your attention is that now we are not using high dose steroids and we are not using oral corticosteroids. So if he says that medium dose steroids are being given and still the patient is having issues, then what we are going to do in the patient is don't answer then high dose steroids in a patient. Earlier it was high dose steroids or oral steroids. Now it is like what we can do in a patient is we can add anticholinergic drugs. Anticholinergic drugs we can add is like ipratropium, but that's not gonna be like a very good way. So we will have to do a add-on therapy. Add-on therapy would be like drugs like benralizumab, or we might have to add drugs like dupilumab. So basic point is that biologicals needed to be added if the patient's asthma attacks are not responding to medium dose steroids with LABA taken in a patient. And as I say, most of the time he will say symptoms are present both in waking, like sote hue, jagte hue, both at sleeping time and daytime. The symptoms of asthma are present. Normally symptoms of asthma tend to worsen in early morning hours, 4 o'clock, 5 o'clock, bronchial tone is more. But in this guy, like the symptoms are present both at daytime and nighttime. So what we can use in this patient is we can be adding is subsequently add-on therapy that would be like benralizumab, or even molecules like omalizumab can be used in the patient. So just wanted to bring to your attention that oral steroids are not recommended, and high dose steroids would be like not a very good way to manage the patient considering the risk of oropharyngeal candidiasis in a patient. So I think we are sorted for like the asthma question, where the standard part is always that increase in the value of DLCO. And the next one is more pharma oriented but very straightforward. Patient is already having a acute kidney injury. He's having a pre-renal variety. So the RAS system is already upgraded in the guy. And in this guy with a pre-renal acute kidney injury, because it's volume depletion, he says what drug is gonna worsen the patient. Quick answers for the next one, please. Yeah, the drug that will worsen in this case, yeah, I am getting a C also. That's what I'm improvement थोड़ी ना पूछ रहे हैं यार. हम ये डायबिटीज का क्वेश्चन थोड़ी ना है कि भाई डायबिटिक पेशेंट में विच एंटी डायबिटिक ड्रग वुड बी रिकमेंडेड in diabetic nephropathy. So suppose this question wasn't diabetic nephropathy, SGLT2 inhibitors, this question has already been put just to bring to your attention that the question is kidney. That does not mean it's a diabetic nephropathy. यार RAS यहाँ पे already activated है ना, तो अगर आप उसमें एस इनहिबिटर दे दोगे तो फिर तो पर्सन का वॉल्यूम डिप्लीशन, ऐसे समझ लो वॉल्यूम डिप्लीटेड है तो वैसे ही बीपी कम है ना. In any patient who's having volume depletion, the BP is already low. If I'm gonna try and decrease the BP further, it's gonna be counterproductive for a patient. Even if I don't get into that concept of efferent arteriole, efferent arteriole, I'm saying simple things. No, BP of the chap is low because he's volume depleted. If I'm gonna give ACE inhibitor to the patient, it will cause further decrease in the GFR, and that will cause worsening of the patient. So a simple, straightforward, easy question that had to be picked up. It's just like you need to get over that SGLT2 answer in this question. Beta blockers for this particular patient, well, I would say that ACE inhibitor RAS लिखा है ना यार, तो सबसे पहला जो चीज़ है that is like anything to do with RAS stimulation should not be inhibited, and that's primarily based on the fact that the guy is already hypotensive. SGLT2 inhibitor dehydration worsen नहीं करेगा. Okay. ठीक है, फाइन, इतना भी नहीं करेगा ना. एक गोली से तो वॉल्यूम डिप्लीशन नहीं हो जाएगी ना. SGLT2 inhibitor will not contribute to glucosuria and volume depletion to such a large extent that the guy's pre-renal will worsen. So the most important thing that in this patient pay, yeah, I agree, beta 1 receptors would be contributing to even, that's why I said, but the first and the foremost thing is blood pressure is low na. So if blood pressure is low in a chap where kidney is affected, and second, I'll give a reason for that. Even if the renin production is lesser, my point is that efferent and efferent arteriole balance is there. Efferent ACE inhibitor क्या करते हैं, ये efferent arteriole को dilate कर देते हैं. efferent arteriole के dilation से filtration pressure कम हो जाएगा. So now if you're coming into the specifics of the question, the problem is in if I give ACE inhibitor, it will cause a efferent arteriolar dilation, and that efferent arterial dilation will cause a loss of the filtration pressure at the level of the glomerulus. So that is the most important reason why this patient will worsen. So earlier I was trying to explain in a simple way, ACE inhibitor, because angiotensin 2 values are elevated, and then renin, obviously RAS system is coming up. So that's why you picked up that cue. But the technical part is that the efferent arterial dilatation is gonna crash the glomerular filtration rate of the patient. So I think Kishore, the query that you raised is sorted for this one. The answer for this one is B. Okay, moving to the next question. Yeah, it's in focus now. We have the smoker came to the clinic with a pedal edema, abdominal distension, and there's a pulsus paradoxus present. With blood pressure 90/60, that's on the lower side only. He says which of the following is correct about this condition. So you guys can comment for this one now. Yep. Okay. Fine, I am giving you guys all the time in the world to analyze this question. I'm getting 2 as an answer, small sign, and an absent Y descent for this one. So let's work it out, guys. One, the guy is having pedal edema and abdominal distension. So that means that probably some problem with the right side of the heart is there, that the right ventricle is not working properly. That is why pedal edema and abdominal distension and ascites can be present. Then there is a mention of pulsus paradoxus in this patient. So the moment I say the word pulsus paradoxus, 2 things should come in your mind. Either it is a question of cardiac tamponade or it is a question of constrictive pericarditis. Now, if you check out the X-ray in this particular case, the cardiothoracic ratio is normal. Rather, you can see calcification outside the heart. Na? You can see a lot of calcification outside the heart. So pulsus paradoxus is seen in both tamponade as well as in constrictive pericarditis. This particular person is having a lot of calcification outside the heart. The cardiothoracic ratio in this patient is perfectly fine. If I say constrictive pericarditis, there would be small sign and there would be pericardial shudder present in this guy. Considering the pericardial shudder component present in this person, loud diastolic sound represents the word pericardial shudder. Those would be the correct things. If you look at option number C, absent white descent, that would be a feature of cardiac tamponade. Well, white is not tamponade because in tamponade, mainly the blood pressure would be unrecordable and there would be increased cardiothoracic ratio. I know you will argue that, sir, BP is 90/60. That is also low. I agree to that. But the point to be taken is there is no increased cardiothoracic ratio. There is no water bottle heart present in this case. There's no electrical alternance that is described. So I'm ruling out option number C, considering the fact that C is gonna be valid if the cardiothoracic ratio was increased. And we don't have an inspiratory rise of BP now. We have an inspiratory fall of the blood pressure more than 12 millimeter for pulsus paradoxus. The wrong with D is that it's not a rise, it's a fall in pulsus paradoxus by more than 12. So if you look at the data here, it's like the first two statements will make sense here. And therefore the correct answer to this question is option number 1, that is like A and B are correct here. All you have to do in this question is not get distracted by the word the pulsus paradoxus, and then check out the CT ratio. That is like normal. There's a calcification outside the heart, so we'll say constrictive pericarditis, and that's how we move on to the correct interpretation of this question. Okay. कुछ small नहीं भाई, कुछ small breathing तो अलग होता ना. कुछ small breathing is gonna be diabetic ketoacidosis, and कुछ small sign is that rise of JVP on a deep inspiration. So totally different aspects. Okay, moving to the next question, we have this patient coming to the OPD with diarrhea, persistent abdominal pain with diarrhea. Then the laboratory tests are showing elevated serum calcium levels. Our sister is also having a parathyroid adenoma, and then couple of more details given. So I would like you to evaluate this question. Okay, good, Wes. Yes, I think it's a easy one to pick up for this one because there's a mention of medullary carcinoma thyroid na. If medullary carcinoma thyroid is given in this question, then things will become relatively easier for us. Well, what is happening in this patient is yeah, the main thing is medullary carcinoma thyroid is given. With medullary carcinoma thyroid, there is calcitonin. Calcitonin is a tumor marker, but calcitonin can explain the diarrhea of this person also, no? Calcitonin can explain the diarrhea component of this patient. So why this chap is having a diarrhea is not because he's having some Zollinger-Ellison syndrome, which initially might make you think in terms of MEN1 in a patient. It is because there is like MCT described in a question that MCT can also contribute to diarrhea manifestations. And along with that, parathyroid adenoma is also given in the family history. His own serum calcium is elevated. So for multiple endocrine neoplasia, we don't need all the 3 tumors. If at least 2 out of 3 are present, like in this guy, 2 are present. Diarrhea can be explained by the MCT because there's a history of MCT in the mother also, and then there's a elevated calcium which can be explained by the parathyroid adenoma. So considering that, the correct answer in this question would be given as option number B. And the first line was only a distraction, but you guys did well to pick it up that if this question did not mention MCT and only like if I exclude MCT from the question, then we would have answered it as MEN1. If MCT was not in the question, then this would have been a question related to multiple endocrine neoplasia type 1. So this was an easy one to identify. Yeah, the genes to be involved is chromosome 10, ret oncogene is the one that's involved. This is a PYQ that I can say from the INI-CET exam. He said pulse that's gonna be occurring due to operation of the Frank-Starling law. Options are in front of you, and also called as a Corrigan pulse. Calcitonin, calcitonin. That's a rare fact to be remembered, no? Because calcitonin normally the action is gonna be affecting the serum calcium, but we don't have a hypocalcemia. Calcitonin is also a secretory neuropeptide, and this secretory neuropeptide can affect the enterocytes and it can increase the water release, so it can cause a secretory diarrhea. Right, the calcitonin that you were thinking is the one which is coming from that parafollicular C cells, na? So that's not the one that we talk. It's a tumor that is producing this calcitonin. It's a neuropeptide which can act on the enterocytes and open the water channels. Guys, here the simple logic is that you will raise the arm of the patient. When you raise the arm of the patient, blood will go back towards the heart. When blood will go back into the heart, in you and me, not a single drop of blood will go back here. The blood will go back in the heart. It will stretch the heart. And there's a law called as Frank-Starling law that if you stretch the heart, if you cause a dilatation, if you cause an increase in the end diastolic volume, then the heart contracts with more force. What Frank-Starling law says is that if you cause a increase in the end-diastolic volume, the stroke volume of the patient will increase. So the pulse will suddenly become much more forceful. That is what is called as a collapsing pulse, or is called as a water hammer pulse. That initially when you raise the arm, you will feel as if you lost all the pulse pressure. But when the heart will contract the next time, because the stroke volume will be increased in the patient subsequently due to increase in the end-diastolic volume, the next impulse will be very powerful. That's where the word is collapsing pulse, that you get a forceful impulse and then the pulse tends to collapse. This is a feature of chronic aortic regurgitation. The correct answer for this one is option number C. I think this was last time when he said this question was asked pulse operating on Frank-Starling law. That would be collapsing pulse, also called as Corrigan's pulse, that was seen in patients of valvular aortic regurgitation. So we are sorted for this one. Let's move to the next one. We have this patient who's coming with complaints of weakness. There's a ptosis in a patient along with muscle weakness. He has mentioned like this unilateral ptosis, and then he has mentioned about the weakness in the arm of the patient also. Yes, guys, if I say anything more, the keywords would come out and then the answer will become very obvious here. So let's look at your reflexes in this case. He is asking you an investigation to be done. 30-year-old patient, gender is not given, male or female. But yeah, the ptosis component is mentioned. The arm weakness is given in a patient. The reflexes part is also given. And he says what investigation must be done in this patient initially. Okay. Very good, guys. I am getting very good answers in this case. You see, there is a presence of a unilateral ptosis in a patient. And then he has also mentioned left arm weakness in a patient. So in myasthenia gravis, will we be getting is a left arm weakness like this in this patient? And would we be getting brisk reflexes? The answer is not B. The answer is not C, guys. Well, you have to understand that you are sitting for INI-CET exam where the options are gonna be like making you sound like a disease myasthenia gravis, but I have emphasized to you that the only neurological disorder where you get a weakness and the reflexes are normal is myasthenia gravis. In this patient, it is brisk reflexes. By brisk reflexes ka matlab hai the patient could be having a stroke na. This patient could be having a stroke involving the midbrain. This question could be a patient who's ending up with Weber syndrome, where like there's a ptosis on one side and the weakness on the opposite side na. In Weber syndrome, you read a ptosis on one side and a development of weakness on the other side with brisk reflexes in a patient. So because this patient is having a upper motor neuron lesion, the investigation to be done in this case is a MRI brain, because I want to pick up like where is the site of lesion in this patient. So the main aspect to be understood for this question is that myasthenia gravis may the reflexes are always normal. The moment you read myasthenia gravis, I've said this lots of times, I'll say this once again. Myasthenia gravis is one such example where you will always read about muscle weakness in a patient, which will be having a diurnal variation. Like there's no mention of any diurnal variation or symptoms in a patient to make you think in terms of myasthenia gravis. Brisk reflexes means reflexes are fast, na? That is loss of inhibitory control, na? Like clonus, I bol sakta hu. To explain the brisk reflex, I can say like this. If you're nervous, right, nervous and you're trying to drive a car, or if you are even keeping your foot on the ground at an angle, then you might feel that contraction of your Achilles muscle. That is clonus now. Clonus is a brisk reflex, right? I'll say that again, right? If you're nervous, you might have one tremors in your fingers and you might even get contraction of your Achilles muscle, or you get contraction of your soleus muscle due to stretching of the Achilles tendon. So we can get it in nervous state, and we can get clonus in a patient who's having upper motor neuron lesion. So yeah, 3 plus or a 4 plus reflexes would be called as a clonus. The answer to this is MRI brain. The logic to be picked up is myasthenia gravis ke sawal mein, you will never have brisk reflexes present. You will not have a focal deficit. It's not going to be arm weakness in one side. No, it's going to be a universal weakness that would be present. So I think it is sorted for 16th. We can move on to the next one. This would be mixed bag. No, like you'll get one which is tricky, and then you'll get one which would be like a laddu or like a candy to be given. Which of the following is not an AIDS defining illness? Quick answers, please. Why not Lambert-Eaton syndrome? Okay, Lambert-Eaton syndrome will have decreased reflexes, na? When it comes to LES in a patient, Lambert-Eaton syndrome, there is a arm weakness and there is a areflexia in a patient. Na? The Lambert-Eaton syndrome, there is a deficiency of acetylcholine. So rather there would be areflexia in a patient. Lambert-Eaton syndrome has a areflexia Myasthenia gravis has normal reflexes, but query stroke would have brisk reflexes present. Okay, which of the following is not an AIDS-defining illness? So invasive cervical cancer is extrapulmonary TB, not pulmonary TB. Here it is written disseminated TB. So do take care of the fact that if it was pulmonary TB, I would not have considered it, but extrapulmonary TB is, and a primary CNS lymphoma as a patient as well. But then the correct answer for this question would be given as like option number D, oral candidiasis. So this is a relatively easy pick. All you had to do was like you'll get one tricky, then you'll get an easy one. So you need to maintain the scoring, has to be consistent. It's like one run of every ball, all that you need to do, and try to minimize the negatives or dot balls as people do in cricket. Okay, moving to the next one. We have this patient who's come to me with shortness of breath, and the pulse rate is like 100. That's okay. Blood pressure is also decent. I mean, I'll say not like very high, but yeah, diastolic blood pressure is little on the higher side. Respiratory rate is slightly increased as well. So from the vitals perspective, like at least not a crashing patient. There's a cavity in the right upper zone, and echocardiography shows a pericardial effusion. Sputum is positive for AFB. So if I look at the information, one is giving me TB, and second is telling me about a fluid around the heart. So it's a case of extrapulmonary TB. So common in our case, patient is having a tubercular pericardial effusion, and he says like, what would you be doing for management of this patient? So in any patient with tubercular pericardial effusion, I need to give Veta T so that the TB pericardial effusion can be taken care of. Urgent pericardiocentesis is coming up multiple times. And to do for CB, I mean, diagnostic and therapeutic both need to be done, but BP is okay, na? Hey, BP is 130 by 100. Diastolic blood pressure is rather on the higher side of what it should be. So we will not do a pericardiocentesis in this patient. Pericardiocentesis would be done for a crashing patient. And why not a diagnostic? I mean, why not a therapeutic pericardiocentesis? If the sputum is showing acid-fast bacteria, I don't need to do a pericardiocentesis in a patient. Reason why C is not there is, because the BP of the patient is rather on the higher side. On the other hand, I'll say like this, I'm not strong to say normal. The BP of this patient is rather increased. So that is the reason why I will not do a therapeutic pericardiocentesis. And for diagnostic purposes, I am saying that if person is already sputum for acid fast bacteria positive, then there is no point of doing point number B also. So B and C are ruled out. I'm left between two. One is giving diuretics, which will not, like there's no pulmonary edema present in this case at the moment that I need to give high dose IV diuretics. So it's just start ATT and monitor the patient with serial echocardiograms. The correct answer for this one is option number D. I'll say that again, B बीच में बहुत बारी आया, like you know, B came up multiple times. Diagnostic pericardiocentesis. First, we usually don't do a diagnostic pericardiocentesis. Now, in India, empirical ATT would be started in a person suspected of tubercular pericardial effusion. And second point to be understood is that in the person, considering that the BP is stable, we would not do an urgent one. So B and C are off the radar. Diuretics because there's no pulmonary edema. So we will have to answer this as a case of option number D, that is start anti-tubercular treatment and monitor with serial echocardiograms. Okay, somebody mentioned why brisk reflexes. यार ये तो baseline है ना, first year of medical school. In upper motor neuron lesion, we have loss of inhibitory control. In upper motor neuron lesion, we always have is loss of inhibitory control. जब कंट्रोल चला जाएगा तो जो रिफ्लेक्सेस होते हैं वो हमेशा फास्ट हो जाते हैं. सो ब्रिस्क रिफ्लेक्सेस आर अ फीचर ऑफ अपर मोटर न्यूरॉन लीजन. दैट इज हाउ आई वाज picking up stroke in the patient. No, that there was a arm weakness on one side and there was a ptosis. He did not mention left-sided or like crossed feature were not given, which is a feature of midbrain stroke. But if somebody is having ptosis, third nerve palsy, and an arm weakness, that means that probably like the blood supply in the midbrain in some area is affected, due to which like the oculomotor nerve and the crus cerebri could have been involved, which can explain the motor manifestations of a patient. So I think it's clear now. One line, loss of inhibitory control. That's why we get fast reflexes in a patient. And sometimes these reflexes can be so fast as well that it can be called as a clonus as well. So we are sorted for 17th and 18th. Moving to the next one. This gentleman came with palpitations and lightheadedness. The ECG showing capture beats with a broad QRS tachy. And then there is mention of Canon A waves also. Like he has himself written the word Canon waves or Canon A waves. I can say super large A waves are present. You guys can do the honors now. I mean, I've already solved the question for you. Super large A waves, Canon A waves would be seen with respect to patients having AV dissociation. AV dissociation would mean that the atria and ventricles are not working in coordination. Both are contracting together. If atria and ventricle will contract together, we will be having is like a super large A wave occurring in a patient, and the super large A wave, because atria ka power and ventricle power is added. So the atrial and the ventricular power is added, we'll have is like a super large A waves in the patient. So it says like, what is the answer? Okay, guys, let's look at the answers for this one. Yeah, I think you don't need to even look at the JVP funding. I'm bluffing as an examiner will. भाई लिख दिया ना वो capture beat. Capture beat is a feature of ventricular tachycardia, broad curious tachycardia. That word itself is sufficient for you to know that it is the case of VT, because AV dissociation is seen one with complete heart block. But for complete heart block, there would be a bradycardia, right? This patient is having palpitations, so answer cannot be complete heart block. Answer is not Stokes-Adams syndrome, guys. स्टोक्स एडम सिंड्रोम में तो ब्रैडिकार्डिया होता ना. अगर इसका मैं बोलता भी पेशेंट केम विद लाइक डिजीनेस, सिंकोपल एपिसोड्स, ECG shows prolonged RR interval, ECG shows bradycardia, then you could have thought in terms of Stokes-Adams syndrome. You could have thought in terms of complete heart block. B and D basically mean the same only. B and D mean the same only, complete heart block. And if you look at Stokes-Adams, they basically mean the same only. All you had to pick up was this is not a question of, Stokes-Adams syndrome, because there's no bradycardia. So बच गया एक ही VT ना, ventricular tachycardia, that has a AV dissociation. And you can solve this question by simply looking at the first line, second line, capture beats and broad curious tachy is always a feature of VT. So we are sorted for the 19th one as well. Like again, mixed bag, I can say. Some which are requiring logic. This is like logical types. Not too much of knowledge required. BP is not crashing, so I'll not do a pericardiocentesis, and the remaining logic I've explained. This is like a spotter. You read it and you know the answer. This is the one that we discussed where we assume answer is myasthenia gravis, turned out to be something else. So this is the mixed bag approach that I'm trying to tell you, that some of them are gonna be like so easy that you'll be wondering, why the hell did I ever go for a coaching for it, or why did I attend even a class for it? I could have solved it myself. There would be some where you need guidance. This is one such example where you need to be patient and coming to an answer. And then there are some where like, this, if you got it right, cool, but if you got it wrong, then I can say it's a silly mistake. इसी को बोलते हैं. You knew the answer to the question and still like we will be, we might still get it wrong. Okay, G. So we are trying to replicate the same thing. Fine, guys. Let's move on to the next one. This is a 45-year-old lady. She's having Graves' disease and she's coming to the ER with this fever for 103. So in Graves' disease, if you read a question where there's like a fever, palpitation, agitation, that means like some kind of storm is happening. If I say more, the answer will become obvious. Person of Graves' disease, if you have excessive already there is a sympathomimetic drive that's more, and now that sympathomimetic drive is going in crazy, I would say. So there's a heart rate of 140, blood pressure 160 by 100, crepes in both the lung fields are coming up. So hypertension could be causing even a heart failure. And then there's a elevated T4 and a suppressed TSH. That lab report is classical for Graves now. TSH is undetectable, and he says which of the following will be used for management of this patient. So the case is that of thyroid storm. I'm waiting for the answers here. What I'm picking up is option number 3 in the discussion, that is like a B and then a C and then a D in this patient. I can pick up a 4 there as well. That is like all the drugs would be used for management of this patient. So let's work out the rationale here. There's a thyroid storm. There's a tachycardia. There's an increase in blood pressure. There is an increase in body temperature of this patient, and there is also presence of bilateral crepitations. That bilateral crepitations are telling me that the patient is probably going into heart failure, and therefore you can work out that the answer to this cannot be, you cannot give propranolol to somebody where the patient is already in heart failure. Even in the thyroid storm discussion right here in front of you, I think this is a PYQ only of, I think, I don't remember the year, but like the point is thyroid storm is causing heart failure. So beta blocker तो देते नहीं ना heart failure के केस में, तो propranolol तो बाहर ही हो जाएगा. So answer cannot be A, B, C, D in this question. Some people said 3. दैट इज SSKI प्रोपरलॉल प्रोपाइलथायोरेसिल। अगेन वो प्रोपरलॉल फिर आंसर नहीं होगा ना, क्योंकि हार्ट फेलियर है ना पेशेंट में। तो क्या बच गया, A, B और D बच गया ना। तो द करेक्ट आंसर इज हाइड्रोकॉर्टिसोन, बिकॉज लॉट्स ऑफ टाइम थायराइड पेशेंट्स कैन बी हैविंग अ concomitant I mean, one, it's an endocrine emergency. One, why hydrocortisone मैं देना चाहता हूँ is because this is an endocrine emergency. So one logic is simple, that why we want to give hydrocortisone for this person is that it will help in patient tiding over the crisis. Second is lots of time autoimmune disorders like Addison could also be present in these patients. So rather that sympathomimetic drive can worsen the Addison status of a patient. Addison in crisis can be triggered. तो hydrocortisone तो देना है क्योंकि endocrine emergency है. Even if you don't get into the concept of coexistent autoimmune disorders, the point is endocrine emergency. SSKI is given because of the Wolff-Chaikoff effect. I mean, we have to give saturated solution of potassium iodide. It will help in Wolff-Chaikoff effect and will help in managing this patient relatively better. SSKI is saturated solution of potassium iodide. This saturated solution of potassium iodide causes decrease in the process of iodine trapping. And if you downgrade the iodine trapping, then the thyroid hormone production will also become relatively lesser in this patient. So we would be like, using SSKI because I want to decrease the production of thyroid hormone in the patient. Yeah, the heart rate is increased. Why? In heart failure में तो tachycardia ही तो होता है. हार्ट फेलियर में तो tachycardia ही तो होता है. One of the earliest signs of heart failure is tachycardia. If you give a beta blocker, it will kill the patient. Because beta blocker अगर heart failure में दे दिए तो you are killing some, you are cutting off, you are putting on the brakes on something that is ensuring life. Fast beating is causing clearance of pulmonary edema. This heart rate of 140 at the moment is good. I am saying 140 is good is because it is clearing the pulmonary edema component. If I put on the brakes, then the tachycardia component will go, heart will beat slower and slower, and therefore pulmonary edema will worsen in a patient. So we don't give beta blockers to this patient. And propylthiouracil we can give rectal, no? We can give a nasogastric tube, not endotracheal tube, not an endotracheal tube. It would be given via NG tube in the patient, or it would be given rectally to the patient, not endotracheal. It is NG tube or rectal administration that would be done. So the correct answer for this question is option number 2. In case you like got it correct, cool. Otherwise, if you got it wrong, just analyze these thyroid questions always carefully, because if a person is in heart failure, तो बीपी तो अच्छा, तो हाई आउटपुट हार्ट फेलियर बोलते हैं ना इसी को. हाई आउटपुट हार्ट फेलियर यही तो होता है ना. अगर बीपी कम होता है तो हार्ट फेलियर नहीं होता है. दैट इज बिकॉज ऑफ कार्डियोजेनिक शॉक. पढ़ो, कार्डियोवैस्कुलर सिस्टम पढ़ो हो तो फंडे क्लियर होंगे. हार्ट फेलियर के पेशेंट में जो हाई आउटपुट हार्ट फेलियर होता है ना, वो यही होता है. ग्रेव्स डिजीज में पहली चीज़ जो होती है, जब भी फार्मा में भी हार्ट फेलियर पढ़ाते हैं ना, तो बोलते हैं हाई आउटपुट हार्ट फेलियर, लो आउटपुट हार्ट फेलियर. This is classical example of high output heart failure, where the heart is beating so fast that it is exceeding the oxygen capacity delivery. Limitation है ना, कितनी ऑक्सीजन दोगे. High output heart failure is heart rate increases so much that coronary arteries are not able to cope up, and that is why there's a deterioration of the cardiac function in the patient. So here, like, it's not depth by, this is concept only, that tachycardia is like Graves disease is a classical example of high output heart failure. And in heart failure, we don't give a beta blocker in a patient. Okay, fine. We are sorted for this case. Yeah, esmolol can be used. Esmolol we can use, but again, it would be very, very dicey dicey thing to do. So better to manage the patient with hydrocortisone and SSKI and propylthiouracil. Okay. Moving to the next one, we have this chap, shortness of breath with effort intolerance and a pansystolic murmur, which is decreasing in intensity with loud inspiration. So you guys can do the talking here. Pansystolic murmur would be all through the duration of systole. So we call it a holosystolic murmur or a pansystolic murmur. The chap is having breathing difficulty also. If I say anything more, the answer of this person will become very, very obvious. So in this case, he says like the murmur is, yes guys, the murmur is decreasing in intensity with loud inspiration. Because it is decreasing with inspiration, so it is a murmur of the left side of the heart. It is the left heart that is involved in this case, not the right heart. If the murmur was increasing in intensity with loud, then it answer would have been tricuspid regurgitation. Answer to this question is not C, guys. It is D, because mitral regurgitation is left-sided murmurs decrease with inspiration and right-sided murmurs increase with inspiration. Logic is more blood will come, no, when you take a deep breath. more blood will come in the right side of the heart, so it will cause more turbulence to be present. So if this question said increases in intensity, I would have answered as tricuspid regurgitation. If it is decreasing in intensity, I'll answer this as mitral regurgitation. So that's like the exclusion part that would come in here. So we had again a 50-50 response there. Initially it was C, then immediately people corrected to option number D there, but a good one for to be picked up. Okay. 55-year-old man is having heart failure with significantly reduced ejection fraction. So we're talking about HFrF. And in this patient, which of the drug will significantly lower the mortality of this patient? उल्टा होता है ना, दैट राइट साइड में ज़्यादा आता है, लेफ्ट में कम आता है. दैट्स हाउ इंट्राथोरेसिक प्रेशर बढ़ जाएगा ना. तो इंट्राथोरेसिक प्रेशर बढ़ने से जो पल्मोनरी वेन है वो कॉन्स्ट्रिक्ट कर जाएगी, तो लेस ब्लड विल कम इन द लेफ्ट साइड, बट राइट साइड का वेनस रिटर्न इंप्रूव हो जाता है. दैट्स हाउ फिजियोलॉजी ऑपरेट्स. Okay, guys, so he says which of the following drugs will significantly lower the mortality in this patient? SGLT2 inhibitor is also there and ARNI is also there. Guys, the gold standard in heart failure now is ARNI. It is A. First answer is ACE inhibitor. It is not SGLT2 inhibitor, guys. The major drug that reduces mortality is like this only. Na? It is A, then it is B, then it is gonna be gliflozin. So most guys are under impression from pharmacological questions that gliflozin is answer to all the questions. No, man, it is not the case. The only time you'll answer gliflozin as one of the important drugs is for diabetic nephropathy. I agree to that. But otherwise, for heart failure cases, it is gonna be A more than B more than C. A is ACE inhibitor, na? So if ACE inhibitor is not there, or there, like instead of ACE inhibitor, we can give ARNI to the patient. So the main drug that will be causing a substantial reduction in mortality is valsartan. Along with valsartan, there would be that is the second drug that we use is sacubitril. The mechanism of sacubitril is that it will inhibit the degradation of BNP, B-type natriuretic peptide. If I inhibit the degradation of BNP, there will be more natriuresis, and more natriuresis could be beneficial to me because if I lose salt, it will be causing decrease on the stress on the heart. So the basic point is valsartan and sacubitril are the major mortality reducing inhibitors in a patient. In fact, for patients with heart failure, you know, one of the important intervention, even more successful than this, that I can mention at the moment is cardiac resynchronization therapy, CRT, right? CRT. So one of the things that makes a very significant impact in heart failure, especially if it is like significantly very severe heart failure contributing to development of cardiomyopathy in a patient that is dilated. So we can do for a CRT, then we can be using ACE inhibitors, then beta blockers, and then gliflozin. So that's how the mortality reduction is. Max mortality reduction is with CRT, cardiac resynchronization therapy, that will make the ventricles beat together simultaneously. But that is like interventional cardiology. So we're talking about drugs at the moment, which is why the answer in this question is नहीं, इसमें तो एक्सेप्ट नहीं है ना. Aldosterone antagonist भी इसके बाद में आते हैं ना. Aldosterone antagonists are used only to reduce the edema component. So the logic is like this, na. First it is A, then it is B, then it is aldosterone antagonist, and then is gliflozins that are added. Gliflozins reduce mortality. मैं मानता हूँ high gliflozin will work here, that it will cause salt loss, no? So salt loss will be beneficial for me. But from the clinical trial perspective, it is A that would always be working more significantly. Okay, somebody mentioned inotropes for the patient. So inotropes तो पहली बात तो कार्डियोजेनिक शॉक में देते हैं ना, और दूसरा inotropes mortality कम नहीं करते ना. None of the inotropes have been shown to reduce mortality, guys. None of the inotropes have been shown to reduce mortality. ARNI is used in HFpF and also in HFref now. We can be using it in heart failure with reduced ejection fraction also. Like if ACE inhibitor can't be used, so we can be then using valsartan and sacubitril in a patient. So it's used in HFpEF, that's okay. But even in HFref, ARNI can be used in the patient. Inotropes don't reduce mortality, guys. Inotropes don't reduce mortality. They are used in cardiogenic shock. None of the inotropes. हम पहले यूज करते हैं नॉरएपिनेफ्रिन. आजकल तो डोपामिन के लिए मना करता है ना, क्योंकि वो इरिथमिया करवाता है. So though he mentions low dose dopamine, but then the point is dopamine is pro-arrhythmogenic. Then is dobutamine का issue ना, कि dobutamine जो होता है वो actually alpha 1 को block करता है, so it will cause hypotension. So we don't use dobutamine if the BP is less than 100. If the BP is less than 100 systolic, we don't use dobutamine. So norepinephrine is used, but then none of these drugs would be like causing significant reduction in mortality. The mortality would be like the ones that I mentioned: CRT, ACE, then B, and then gliflozins. I mean, if ACE inhibitor can't be used, you know, angioedema हो गया, dry cough हो गया, whatever. Like if ACE inhibitor can't be used, then ARB can be used. No? We can use ARB in a patient, and if you add nephrilysin inhibitor, that will give advantage of natriuresis in a patient. So the correct answer for this is option number A. We are talking about hardcore data, ventricular remodeling जो सबसे important drug है वो ACE inhibitor है फिर भी, right? So there's a table that is given in Harrison, उसको follow कर लो, या फार्मा में अंकित सर का डेटा सुन लो, सेम चीज़ है जो उन्होंने बताई है, that is the same thing that I'm telling you at the moment. So we sorted for this, ये आते ही आता है हार्ट फेलियर वाला डेटा, it is A that is to be given over B. डायबिटीज पेशेंट है, डायलेटेड कार्डियोमायोपैथी में देर इज अ सिवियर माइटल रिगर्जिटेशन, या अगर हार्ट फेलियर है तो हमें एल्गोरिथम तो सेम ही यूज करना है ना. क्रॉनिक हार्ट फेलियर में HFrEF में द सेम एल्गोरिथम इज टू बी यूज एज इज मेंशन्ड हियर ओनली. वेरापामिल, हाँ वेरापामिल नहीं देते ना पोस्ट MI पेशेंट में, या पोस्ट MI पेशेंट में या किसी भी पेशेंट में अगर हार्ट फेलियर है, खासकर पोस्ट MI तो कार्डियक आउटपुट कम होता है ना. अगर पोस्ट MI में किसी को कार्डियक आउटपुट कम है और मैं वेरापामिल देता हूँ, तो वेरापामिल से तो कार्डियक आउटपुट और भी कम हो जाता है, बिकॉज इट डिक्रीज इट बेसिकली एक्ट्स ऑन द AV नोड ना, सो इट विल डिक्रीज द कंडक्शन थ्रू द AV नोड, इट विल डिक्रीज द कार्डियक आउटपुट. सो वेरापामिल कैन कॉज वर्सनिंग ऑफ अ पेशेंट ऑल्सो. Like lots of time it might be patients who may not have an MI but they might be having coronary artery disease ना, ऐड हो सकता है पेशेंट को. तो कॉर्नरी आर्टरी डिजीज के पेशेंट्स में इश्केमिक कार्डियोमायोपैथी है, तो वेरापामिल कैन कॉज वर्सनिंग इन द पेशेंट, सो दैट्स व्हाई इट्स नॉट अ कैल्शियम चैनल ब्लॉकर, इट इज A देन अ B that is to be used. Yeah, somebody mentioned MBBS 1285, या फार्मा स्टैंडर्ड ना, वेरापामिल नहीं देना है हमारे को. Okay. Moving to the next one, we have this lady. She had unconsciousness at the outdoor ceremony, and she had this lightheadedness with a tunnel vision, and then she fainted. She's woke up alert. She's having a lot of medical history which are present in this case. क्या क्या नहीं देंगे हार्ट फेलियर में ना, acute हार्ट फेलियर में. ओके, सो acute हार्ट फेलियर में क्या नहीं देते हैं, तो acute हार्ट फेलियर में हमेशा आंसर होता है बीटा ब्लॉकर नहीं देंगे. acute हार्ट फेलियर में बीटा ब्लॉकर्स आर गोना बी कॉन्ट्राइंडिकेटेड. और क्रॉनिक हार्ट फेलियर में क्या नहीं देंगे, तो क्रॉनिक हार्ट फेलियर में इट इज CCB, क्योंकि CCB के साथ में सबसे बड़ा दिक्कत है ना रिफ्लेक्स टैकीकार्डिया, दैट इज विद एम्लोडेपिन एक्सेट्रा. And then even verapamil, because contractility of the heart is less. So if you say that what is not given, then the most important thing for acute heart failure would be beta blocker. Beta blockers are given in chronic but are not given in the acute variety. And in chronic heart failure, it is like CCB, the reflex tachycardia component. ये तो आसान क्वेश्चन था यार, वेजोवेगल सिंकोप. सो समटाइम्स वी हैव टू कीप क्वेश्चंस वेरी स्ट्रेट फॉरवर्ड, लाइक इसमें ज़्यादा लॉजिक नहीं लगाना है. चक्कर आ गया, बंदा बेहोश हो गया, and then person regained consciousness, time wasting tactics है, examination is normal, so there is no focal deficit in a patient, so it is vasovagal syncope. बच्चे सीजर होता तो सीजर में तो लाइट हेडेडनेस थोड़ी ना होती है, सीजर में तो पेशेंट विल बिकम अनकॉन्शियस एंड देयर इज अ वायलेंट टोनस एंड अ क्लोनस दैट वुड बी डिस्क्राइब्ड. There would be frothing from the corners of the mouth. There would be a perioral cyanosis. There would be deathly blue color under the lips of the patient. If it was seizure, he should have mentioned regarding frothing. He should have mentioned regarding cyanosis. He should have mentioned regarding the tonus and the clonus component. None of the informations are given there, so that's why like this is ruled out. ऑर्थोस्टैटिक हाइपोटेंशन आप सोचते हैं तो मैं फिर भी मान सकता हूँ. टनलिंग ऑफ विजन इज अगेन अ फीचर ऑफ सिंकोप ना, हिंदी में बोलते हैं ना, आई से दैट इन हिंदी फॉर एवरीबडी, आंखों के आगे अंधेरा छा गया. व्हेन यू सडनली चेंज योर पोजीशन, सपोज यू लाइंग डाउन फॉर अ वेरी लॉन्ग टाइम, it might have happened to you also that if you suddenly change your position for fraction of a second, you feel as if your head is spinning and you might vision might actually decrease, and then everything becomes okay, because in us the aldosterone kicks in, the RAS system kicks in, our BP tends to stabilize. But in vasovagal syncope there would be like a substantial like the person will lose consciousness, then will wake up fresh as if nothing has happened. Okay, fine, moving on to the next one. Okay, that's a good one. Fine. Ill-sustained ventricular tachycardia. Yeah, that's a good one. Ill-sustained VT can contribute to it. True, the dizziness part. If it's lasting less than 30 seconds, yeah, we can be having possible syncopal or pre-syncopal episodes in a patient. चलो जी, 55-year-old पेशेंट प्रेजेंट्स विद हेडेक, नोजिया. देखो मेरा काम है आपको बताना कि कई सुपर इजी होते हैं, कई सुपर ट्रिकी होते हैं, तो माय जॉब इज़ टू गिव यू अ बैलेंस्ड अप्रोच. अगर मैं बहुत डिफिकल्ट कर दूंगा तब भी डिफिकल्ट, मतलब फिर मन खराब हो जाता है कि यार ये तो कैसे हो गया. इफ आई मेक इट सुपर इजी तो बोलोगे सर हमें तो आता है, हम पार्टी करेंगे, अगले 4 दिन पढ़ेंगे नहीं, 3 दिन पढ़ेंगे नहीं. तो माई जॉब इज़ टू एंश्योर दैट यू गाइज कीप योर फोकस ऑन एंड यू रिमेन मोटिवेटेड, बिकॉज देखो सही भी हो रहे हैं, कई गलत भी हो रहे हैं, बट एट द सेम टाइम सिर्फ परसिस्टेंस की बात है कि आप बैठे हो मेरे साथ में तो ऑलमोस्ट लाइक घंटा, वी हैव डन 1 hour एंड वी हैव डन लाइक क्रिटिकली वो वाले टॉपिक्स जिसको हमें पता होता है कि आंसर है, एंड देन वी आर लाइक समटाइम्स मिसिंग द करेक्ट आंसर, समटाइम्स वी गेटिंग टू द करेक्ट वन। चलो जी, ये तो बहुत ही आसान सवाल है, मैंने इसको पीछे डाला ही था। ये सेरेब्रल एडिमा दिखाई दे ही रहा है सबको एमआरआई पे, और पीछे की तरफ है तो प्रेस हो जाएगा। द गाइस ब्लड प्रेशर इज सुपर एलिवेटेड, vision loss is there, headache is there, so the diagnosis in this case is press. And for this press, we need to give nicardipine for management of this patient. So I mean, nicardipine or like labetalol are the main drugs that would be used for medical management of this person, and we will have a good prognosis in this one. So the question was on hypertensive crisis with the cerebral edema seen in the occipital lobes, which can explain the vision loss that was occurring in this person. Occipital lobe involvement, and that's why the vision loss component was described. In this one, there is no artery. It's the hydrostatic pressure which is increasing, and that hydrostatic pressure that is increasing is causing more fluid to move into the brain parenchyma. It is causing fluid to accumulate. It is causing the fluid to accumulate between the neurons. It is the vasogenic cerebral edema component which is present. आपने बोला मैलिग्नेंट में क्या कट ऑफ यूज करेंगे, तो अभी वो बोलता है कि इट इज नॉट द वैल्यू, इट इज द प्रेजेंस और टारगेट ऑर्गन डैमेज ना। यू विल सी सो मेनी पेशेंट्स इन योर ओपीडी, वो बोलेगा सिर दर्द था, गैस थी, पहले बोलेगा गैस थी, फिर बोलेगा सिर दर्द थी, आप बीपी चेक किए 200 और आपसे बैठ के बात कर रहा है, दैट इज हाइपरटेंसिव अर्जेंसी। एंड यू आर पेशेंट्स विद 170 हु आर एंडिंग अप विद स्ट्रोक एज वेल, नो। So I mean, there is no like it's the target organ damage that will define, but yeah, 180 is something that would be present there. So the correct answer for this one is yeah, cerebral edema can cause a release of BNP. Agreed. Very much possible. Chalo ji, so let's go through the remaining last 5 questions here. Alcoholic comes with complaints of severe epigastric pain and vomiting, and there's a rebound tenderness with guarding and a rigidity of the anterior abdominal wall. So I'm finding it funny to discuss this one. Yeah, okay. I think बड़े fast आंसर आए हैं। बोयर हैव सिंड्रोम में तो यार मैकुलर स्ट्राइड होता है ना। बोयर हैव सिंड्रोम क्यों बोलोगे, क्योंकि उसमें तो सबक्यूटेनियस एम्फाइसीमा होना चाहिए, क्रेपिटा सेंटर द स्किन होनी चाहिए। Then because the esophagus will burst, there would be perforation, there would be chest pain present in a patient. So suppose this question was mentioning chest pain, यहाँ तो epigastric pain दिया है यार, नॉट चेस्ट पेन है। एज्यूम मत करो ना, बोयरहैव सिंड्रोम तो बनता नहीं है ये, तो भी तो बाहर हो जाता है, राइट। मेलोरीवियस भी आंसर आ रहा है, मेलोरीवियस आ रहा है, तो मेलोरीवियस में तो वॉमिटिंग ऑफ ब्लड होती है। मेलोरीवियसिस, वॉमिटिंग ऑफ ब्लड, हिमैटेमेसिस। अब देखो फटीग आ रहा है, अगर आप ये क्वेश्चन को मैसअप कर रहे हो तो दिस इज लाइक फटीग कमिंग इन, कि भाई आप क्वेश्चंस कर रहे हो तो थक जाते हैं। Boerhaave syndrome is rupture of the esophagus where there's a perforation of the esophagus, contents will spill over into the mediastinum, so you get a chemical mediastinitis. That's why chest pain, and there's puking, and there's an emphysema not given in the question. In malarious, it's a non-life-threatening bleed. The BP of the patient will remain normal, and portal hypertension होता तो portal hypertension में फिर rebound tenderness की होगी यार, peritonitis है ना। It's probably a query peptic ulcer disease. The guy could be having is a query PUD, and that PUD could have resulted in a perforation. अगर ये portal hypertension होता तो portal hypertension के लिए कुछ तो देता, splenomegaly, caput medusae. Some evidence of damage should be given in a question with respect to the liver, but there's no splenomegaly, there is no caput medusae. He is written alcoholic, that is okay, but there has to be some stigmata related to liver damage that could be given in a question. So in those circumstances, like here the answer is simple peritonitis, which could have contributed to this. तो अल्कोहल बेंच ड्रिंकिंग वो तो हो ही सकता है ना, अल्कोहलिक वेंट टू अ पार्टी तो भैया फ्री में मिलेगी तो पियेंगे ना। ये इंडियंस तो देखो ना कहीं पे भी पीना शुरू कर देते हैं, पीते तो गोरे लोग भी हैं, बाहर भी लोग पीते हैं, बट इतना शोर नहीं बजाते। इंडियंस हैं कि पीने के बाद में दे लूज ऑल इनिबिशंस बिकॉज अल्कोहल कॉजेज लॉस ऑफ इनिबिशन। सो दैट्स द ओनली प्रॉब्लम, दैट सोशल प्रॉब्लम्स क्रिएट कर देते हैं। ओके जी, द करेक्ट आंसर फॉर दिस इज ऑप्शन नंबर ए, peritonitis. Yeah, not every alcoholic will end up with malarious and Boyrave syndrome is the learning point for this question. Okay. पेनलेस हिमैटेमेसिस तो बच्चे पेनलेस ही होता ना। हिमैटेमेसिस तो पेन तो पेनफुल तो नहीं होता ना। हिमैटेमेसिस तो आप आई थिंक आप हेमाटोचीजिया से मिक्सअप कर रहे हो ना, पेनफुल हेमाटोचीजिया, पेनलेस हेमाटोचीजिया। हिमैटेमेसिस तो ब्लड की वॉमिटिंग तो पेनलेस ही होती है। चलो जी, ओके फाइन। तो renal tubular acidosis में hypokalemia तो होगा because they would be damage to the alpha intercalated cells, so potassium will not be reabsorbed and hydrogen will not be excreted. So since I put a crosshair, so there you can see that there would be a caliuria occurring in this patient, so there would be a hypokalemia occurring. Then another thing that will malfunction here is called as CASR, that is called as calcium sensing receptor. So even calcium will not getting reabsorbed, and therefore we will be having is a hypercalciuria. There's a hypercalciuria, so A and B both make sense. And because there's an inability to excrete hydrogen, so there would be bicarbonate lesser, that is understandable. But urine pH तो basic point मैंने बोला RTA1 में English से करो. RTA1 is a condition where there is a inability to acidify the urine. Try to solve this question by English only. The word is inability. Hydrogen निकल नहीं रही ना, so inability to acidify the urine. So urine pH cannot fall less than 5.5. ना, you cannot have a acidic pH of the urine. The pH will always remain on the higher side. So that is the answer in this case. That urine pH cannot be less than 5.5. Just go by English, man. You cannot put protons in the urine, so you cannot cause the urine pH to go less than 5.5 for this one. And yeah, this condition will have Dr. Fuse, that is Nagma component will come in here. The points are hypokalemia due to kaliuria. There is a hypercalciuria, CASR is not functioning, and there's a hydrogen ions which are not getting excreted, so that's why there's a metabolic acidosis occurring in the chap. So 26 is sorted, we move to 27th. This guy came with fatigue, weight loss, and hyperpigmentation of the skin. Hyperpigmentation means that either it could be Cushing, it could be Addison disease, or it could be even a possibility of Nelson syndrome. There is a dizziness, lightheadedness, especially when standing up. So postural hypotension is given in this guy. Along with postural hypotension, sodium is low. Potassium is on the higher side, which means that aldosterone is coming in the picture. Cortisol values are also given to be lesser. So the diagnosis in this case is Addison. In Addison disease, we'll always be having feedback mechanism operating. So ACTH values will begin to rise. And when ACTH will rise, there would be a hyperpigmentation that is explained by this in this question. So like we know that we are dealing with Addison disease in a patient, primary Addison disease. He says what test would be done in this case. So ACTH levels in this person तो बढ़ जाएंगे ना. तो ACTH levels तो Cushing syndrome में भी बढ़ जाते हैं. तो answer cannot be A ना. Answer cannot be A, man. Answer cannot be A. ACTH levels can be increased even in lung cancer ना. Like let me say, person is having ectopic ACTH production. Cushing syndrome याद है? तो ectopic ACTH production which causes Cushing, उसमें भी ACTH इंक्रीज होता है. तो ACTH से तो डायग्नोसिस नहीं करेंगे ना इसमें. वी विल डू डायग्नोसिस ऑफ दिस पेशेंट बाय ACTH. आई मीन एडिसन डिजीज इज डायग्नोस्ड बाय ACTH स्टिमुलेशन टेस्ट, एंड इन दिस केस द टेस्ट विल फेल. अब सी आ रहा है आंसर. सेलाइन इन्फ्यूजन टेस्ट इज डन फॉर, सेलाइन इन्फ्यूजन टेस्ट इज डन फॉर डायग्नोसिस ऑफ कॉन सिंड्रोम, फेलियर टू सप्रेस अल्डोस्टेरोन प्रोडक्शन. एक बार सारे एंडोक्राइन डिजीज लिखना, उनके IUC लिखना अपनी हैंड राइटिंग में. मैंने तो कराई है RR में. आई वांट यू टू राइट डाउन ऑल द एंडोक्राइन डिजीजेस एंड देयर इन्वेस्टिगेशन इन योर ओन हैंड राइटिंग, अदरवाइज इस टाइप के क्वेश्चंस में मेस अप होने की पॉसिबिलिटी रहती है. सलाइन इन्फ्यूजन टेस्ट इज डन फॉर कॉन सिंड्रोम. कॉन सिंड्रोम विल हैव हाइपरटेंशन, हाइपोकलीमिया. अगर आप सॉल्ट खाएंगे तो आपका मेरा एल्डोस्टेरोन प्रोडक्शन विल गेट सप्रेस्ड, कॉन सिंड्रोम विल नॉट गेट सप्रेस्ड. देन इज CRS स्टिमुलेशन टेस्ट. CRS स्टिमुलेशन टेस्ट इज डन फॉर डायग्नोसिस ऑफ पिट्यूटरी एडिनोमा, मैन. That is Cushing syndrome. जब आप CRS से स्टिमुलेशन करोगे तो पिट्यूटरी एडिनोमा विल कॉज अ मोर राइज ऑफ ACTH. द करेक्ट आंसर इज जो मैंने बोला, एडिसन डिजीज का इन्वेस्टिगेशन चॉइस होता है ACTH स्टिमुलेशन टेस्ट. आपकी आईज ढूंढ रही थी ये वर्ड जो कि लिखा नहीं था, उसकी जगह उसका ऑल्टरनेटिव नाम लिखा था जो मैंने पढ़ाया भी हुआ है, कोसेंट्रोपिन टेस्ट. इफ यू messed up for this question, my suggestion to you is कि एंडोक्राइन के सारे डिजीज लिख के उनका इन्वेस्टिगेशन चॉइस एक बार जरूर लिखना. If you are able to figure out the answer in the first go, cool. Addison disease, investigation choice is ACTH stimulation, workable. But in case you somehow had an error in this one, then just practice की बात है कि 1 मिनट के अंदर क्योंकि वर्कआउट करना होता है. तो आंसर तो अब नाउ यू आर क्लियर अबाउट इट नो कि दिस इज अ एडिसन डिजीज. व्हाई? बिकॉज दिस इज अ पोस्टल हाइपोटेंशन. सोडियम एंड पोटेशियम आर गोइंग इन ऑपोजिट डायरेक्शन. दैट आई ऑलरेडी सेड. एल्डोस्ट्रॉन में हमेशा सोडियम पोटेशियम ऑपोजिट चलता है. Cortisol is himself mentioned to be low in a patient. ACTH is elevated, so there's a hyperpigmentation. So the diagnosis became clear. The only thing is that you have to pick up the best test for diagnosis of this condition. The answer is B. Okay, ji. Uh, this was analytical variety. Next one is a spotter. Like 27th is like analytical, 28 is a spotter. So yes, guys, which of the following will lead to hyperphosphatemia? PTH तो phosphate का loss ही कराता है. Calcium is more and phosphate is less in a patient with increased serum alkaline phosphatase. मल्टीपल माइलोमा में कैल्शियम हमेशा इंक्रीज ही होता है. फॉस्फेट वैल्यूज कैन बी नॉर्मल इन द पेशेंट बिकॉज ऑफ बोनीलाइटिक लीजन्स इन अ पर्सन. And even SAP values are normal in multiple myeloma because it is not the osteoblastic activity, it is rather the cytokines produced by plasma cells which will cause lytic lesions in a patient. Vitamin D intoxication will again cause calcium values to be super elevated in a patient because like if you have more of vitamin D going in the body, then calcium levels will rise. But then CKD is a patient where like calcium is less and phosphate is always elevated because it is not getting excreted. The reason for that is low GFR. So for calcium metabolism, I think it is pretty straightforward. CKD would contribute to hyperphosphatemia in a patient, and that is bad. Phosphate causes calcification. It binds to calcium in the tissues and causes hardening of blood vessels. And one of the blood vessels it can harden is the iliac artery, which is used for that anastomosis with the graft. No, like if you do kidney transplantation, you need a vascular anastomosis that is done with the iliac artery. Now, if the arteries become calcified, that vascular anastomosis would not be possible. So this would be a straightforward one. The next one says which of the following is not associated with Cushing syndrome. So Cushing will be having, I mean, obviously the guy will become fat and then there is going to be proximal myopathy occurring in a patient and metabolic alkalosis. But CKD में यार ये तो आसान है ना. CKD के जो पेशेंट्स होते हैं उनमें विटामिन डी की कमी होती है ना. तो विटामिन डी की कमी की वजह से कैल्शियम लेस होता है और फॉस्फेट बढ़ जाता है और सैप की वैल्यू बड़ी होती है ना. बस इतना ही याद करना है. आप पढ़ लेना कैल्शियम मेटाबॉलिज्म मैंने समझाया हुआ है उसमें भी. दो आई सेट द डेटा वेरी स्ट्रेट फॉरवर्ड. लो कैल्शियम एलिवेटेड फॉस्फेट, तभी तो फॉस्फेट बाइंडर्स देते हैं ना. एंड सैप वैल्यूज आर एलिवेटेड. Not associated with Cushing syndrome would be a hyperkalemia because cortisol will cause epithelial sodium channel activity. So hypokalemic metabolic alkalosis would be occurring in a patient. So it's relatively easier one. Okay guys, so we have a patient with hematochezia. Why metabolic alkalosis here? Okay, fine. देखो जी फटाफट से we are solving metabolic alkalosis. Cushing syndrome will have more of cortisol. Cortisol will stimulate a channel by the name of epithelial sodium channel. This is how it works. It will cause sodium and water to come in. That will explain like there would be hypertension occurring in patients of Cushing syndrome because more salt and more water are coming in. That is good news. Bad news. The more bad news is that there would be exaggerated loss of potassium and hydrogen because epithelial sodium channel काम कैसे करता है? It causes urinary loss of potassium and hydrogen. और यहाँ पे there would be more than normal loss. So that is why there's a metabolic alkalosis. Hydrogen loss in the urine explains the hypokalemic alkalosis in Cushing syndrome. The logic is cortisol stimulates epithelial sodium channel and this is how epithelial sodium channel works. Okay, ji. Moving to the next one. Okay, so this would be the last one for today, guys. The question says which of the following investigation is first line for a patient with hematochezia with hypotension on admission? Yes, straightforward one. Every time you're having hematochezia, lower GI bleeding, but it is associated with hypotension, then we need to go for upper GI endoscopy because the person could be having a peptic ulcer that is bleeding. Mostly it's like a duodenal ulcer that is causing bleeding and that's why hypotension component is there. So what we will do in this patient is a upper GI endoscopy and not a colonoscopy. The last three questions that I've discussed are the repeat ones that I have like already spoken here before you. So it's like the initial first few ones that you basically need to take care of. So these are the important aspects which I wanted you to be, practicing. So do comment in the chat with respect to like, do analyze how many of these did you get right and how many were the negatives. And the negatives are the ones that need to be minimized. So we have had a mixed bag of questions that we've discussed here, like here heart failure was there. So the answer tended to change. So, like I can say, do scroll through the the discussion fast or in the PDF in the Telegram subsequently and check out like how many of these did you get right. So it's like we're sorted for today, guys. Thank you so much for joining in, and I'll keep on seeing you. I mean, obviously there are a lot of more exams to come. INICET is just one of those small things in the middle, one of the big exams, but yeah, one of the small hurdles I can say because you are destined for better things as always. So yeah, guys, we will be doing RAS wala question. अच्छा, वो एस इनहिबिटर वाला, तो यार उसमें सिंपल लॉजिक है ना कि लाइक द AKI पार्ट वाज बीपी इज ऑलरेडी लो, सो इफ आई गिव एस इनहिबिटर द बीपी विल बिकम even more low in a patient, so I'll not be comfortable giving like ACE inhibitor to somebody having a acute kidney injury. Exam strategy, bhai, I took a Zoom session yesterday, but yeah, the session is to do about 190 questions, in my opinion. Though it depends on the type of exam that comes, but I think that's a decent figure to attempt. And negatives are to be kept to the minimum. That negatives are like with practice only. Like nobody can say कि मैंने ये बताया था. Some questions will always come ना. Like last three we discussed, those are like easy ones that anybody can solve. That will not decide a rank, or that will not decide the final scores. It is like some in between that we discussed would basically help us here. So it doesn't matter, like some we might be getting right, some might be getting wrong. This is how life is, right? So it's not the end, it's not the starting, it's like somewhere in the middle that the persistence is most important. Everybody starts off with a bang, everybody wants to finish with a bang, but it's the pathway in the middle where like the persistence is the key. So thank you so much guys for joining in, and okay, fine. सोहेल जी, आप मेरे को मेल कर देना marwamedicine@gmail को पे, and I'll be glad to assist you. So take care guys, God bless you.